hopefully I can offer you some good news for social landlords in terms of the success that the Decent Homes policy has delivered to social housing and the economy in general. And I was lucky enough to be part of a piece of research here at BRE called Quantifying the Health Benefits of the Decent Homes programme. And this is purely the Decent Homes work that's been undertaken by social landlords as opposed to that in the private sector, what little has been done. And it follows on neatly from other BRE research here that basically investigates the cost to society of poor housing. And what we've been looking at is if we can remove health and safety hazards in the home, what are the economic impacts of that? We know it makes good social sense for the people who live in homes to have them modernised, but there are lots of good wider economic impacts that the Decent Homes programme has delivered. And in particular, we look at the health cost savings from that, purely because from a research point of view, quantifying health benefits is a lot easier to do than other economic benefits that are delivered. And why Decent Homes? Well, obviously a lot of progress has been made in the social sector, but there is still a lot of work to do, and we also want to extol the benefits of maintaining that investment that's been taken by landlords. So what will Ian and I cover? We'll basically go quickly through the aims of the research, try and explain as best as I can the key aspects within it, in particular the housing health and safety rating system, particularly those who aren't familiar with it, and a brief look at the English Housing Survey, which is where we got our data from. Go to the juicy bits, the key findings of the research, and then Ian will explore the use of the research for you as social landlords. So the main aims of the research are given there. The main overriding aim is given in bold, but we had to achieve a few targets on the way. The first one we had to do was to estimate the net change in non-decent social homes with health and safety hazards within them, and I'll go into that in a little bit more detail at the moment. We had to estimate the costs of making those homes safe, and we also had to quantify the cost savings to the NHS. In other words, if we hadn't done all this wonderful decent homework, what would it cost the NHS as a result of having those hazards? And putting all those elements together, we could estimate the savings to the NHS arising from making the homes decent over the 10-year period that we've covered. Forgive me if you're not familiar with the HSSRS. I'll try and explain sort of 200 pages of code of guidance in 2 slides. But basically there are 29 hazards that could potentially exist, potential harms in the home. They're grouped into, for example, risks of harm from accidents, such as fall from stairs, risk of fire, burns and scalds, that type of thing. Some are associated with the thermal qualities of the property, like whether someone's at risk from excess heat, excess cold or damp and mould that we've heard a lot about today. There are psychological risks. You know, do people have enough space in their home? Are they free from excess noise? Do they feel secure? You know, what's the risk of entry from intruders? And I've missed one other group as well. Oh yes, infections. We're at risk from infections as well, food hygiene, domestic and personal hygiene. And when we assess a dwelling, someone is assessing 2 key things. First of all, what's the likelihood of a harm incident existing in a property? So take, for example, a fall from stairs. The most vulnerable person would be an older person over 60 or 65. What's the risk of that older person falling down either internal or external stairs at a dwelling over the period of 12 months? And also, what's the probable outcome if that elderly person does fall down the stairs? What's the likely consequence of it? It could be what we call a class 1 harm, the most serious harm. It could be fatal. It could be something else that's serious, like paralysis. It could be something that's still severe and serious, like a hip fracture, something of that nature. It could be a lesser harm, such as just cuts and bruises. And obviously, each of those harm outcomes not only affects the person, but not wishing to be vulgar about it, it will have a different health costs attached to it. So the surveyor or the assessor will go and assess those 2 things, puts it into a magic formula that's given by the Code of Guidance. You get a hazard rating score. The higher the score, the more severe the hazard is. And the top hazard scores are called Category 1 hazard, and if a dwelling has a Category 1 hazard, then it doesn't meet the statutory minimum standard for housing. And this piece of research was essentially trying to do is what was the picture in non-decent homes in 2001, what was the likelihood of each of these harms occurring and the probable outcomes what happened then after decent homes work, how did those probabilities change? And then we put a cost to that in terms of NHS costs. Simples. Just another example of how HHSRS works. Imagine a small child under 5 who's most at risk from falling between levels. You've got 2 flats within this block here. They've both got dodgy window catches that provide no safety or security. The likelihood of that child under 5 years falling is going to be exactly the same in both those properties, but you can imagine the outcomes will be radically different. You're probably all more familiar with what a decent home is. These are the 4 criteria that make a home decent. The first one, that has to meet the statutory minimum standard for housing, well, that is in effect being free from the category 1 houses I've just described, being in a reasonable state of repair, having reasonably modern facilities and services, and providing a reasonable degree of thermal comfort. And you're probably thinking, so how does all this decent homes work that I've undertaken impact on hazards and improve well-being? There's just hopefully a couple of examples in this slide. A nice void that an RSL tenant's left there at the bottom, and just a pretty old kitchen there. All the modernisation work you're doing, you know, to tackle the disrepair as well, it's all going to reduce the risks of food safety and hygiene risks to those tenants. Taking the block of flats on the right needs a basic overall on that one. If you were to apply a whole set of decent homes work on that, improve the insulation, install new windows, put in a better heating system, you're going to reduce the risks that come from a tenant living in an excess cold home, the risks of damp and mould, the noise and entry from intruders. And if you imagine as well the benefits of an elderly tenant on that, that's going to reduce the risk of lots of health problems like cardiovascular disease, respiratory problems, rheumatoid arthritis, that type of thing. Be pleased, I'm not going to go all through this because I know the slides will be handed out to you all after today's presentation, but it really just lists out all the decent homes criterion on the left-hand side, what all the works that you do during your wonderful decent homes programme, the types of harms that it impacts on and hopes to improve, and what the well-being outcomes are on those particular types of works. Where did we get all this data from? Well, we got it from the English Housing Survey, which is currently an annual survey undertaken by Department of Communities and Local Government, and it involves a household survey followed by a physical survey of around about 3,500 dwellings. And the surveyors collect a lot of data on the disrepair at a dwelling, the age of amenities, the age of building components, and that enables us to model decent homes post-field work. So we use the English House Survey to calculate the net reduction in decent homes over the 10-year period of the research. We also used it to estimate the number of hazards that existed in 2001, which wasn't easy because the HHSRS wasn't about then, and the EHS didn't collect this data until 2006. So I haven't got time to go into the details. It was quite problematic, but basically we had to look at the data and get some proxy indicators of what hazards would have existed and the distribution of probabilities of harms, etc. in 2001. The EHS has all the HSSRS information we needed about how hazards stood in 2010, so we could work on our 10-year period, and the EHS also enables us to get the associated costs that we need of the cost of actually improving or mitigating the hazards. Then we had to estimate the reduction in cost to the NHS, and that basically involved estimating how the Decent Homes programme reduced that number of harmful events, you know, all those classes of harms that I spoke about earlier. What was a 2001 position? What was a 2010 position? And then we had to put a cost to each of those reductions in the harms that occurred. And we've worked with the NHS actually to provide those costs. I'll just do a good glimpse there, quick glimpse. Again, I won't go all through it, but you can see the types of hazards on the left and the typical costs that the NHS incurs for the outcomes of that. And generally speaking, as you would imagine, the greater the severity of the harm, the higher the costs. So here we get to some of the good news stories here. We can see throughout the first 10 years of the Decent Homes programme, we estimate that around about 360,000 Category 1 hazards, the most serious hazards in dwellings, have been remedied. And not only that, almost 2 million Category 2 hazards. Now, these obviously aren't as great in their severity, but they're still hazards that you'd want to remedy within properties. And at the top, you can see the huge impact that dealing with excess cold has had on those figures. Yes, it does cost more to install new heating systems and so forth, but that's one of the reasons why there's been such a huge and dramatic reduction in hazards. So what we do, we put all that lovely information about the reduction in decent homes, the reductions in harm, all that reduction in the health costs, and we whop them into a massive Excel spreadsheet that someone far more clever than I invented, and we get these figures. And what those figures show, as I say, I think makes very good reading for social landlords. That from the 10-year period that we've covered in our research, just dealing with those Category 1 hazards has resulted in savings to the NHS of £224 million, with ongoing savings of just under 41 million if those homes are maintained to a decent standard and kept hazard-free. Category 2 hazards, another good story, £168 million worth of savings to the NHS, with ongoing savings of just under 31 million if we continue to maintain those homes to the decent home standard. So put those two totals together, we've estimated at BRE that all the good work you've done in your Decent Homes programme has resulted in health savings of £392 million, and if we continue to make those homes hazard-free going into the future, we're talking about a saving of £71 million. Where did all those savings come from? Well, I've mentioned excess cold, all that work in terms of installing new heating systems, improving your insulation, that's contributed about 1/5 of the savings to the NHS. And perhaps surprisingly, security as a result of that big share, perhaps not so many Category 1 hazards, but the lesser Category 2 hazards had a major impact on the degree of savings. So all that hard work in terms of external door replacements, repairing your communal entry systems, improving your windows, massive impact on the savings to the NHS. And I said that, health costs are relatively more easy to quantify in terms of the economic benefits that have been delivered, but they're not the only ones. And we've estimated through previous research that the savings to the NHS only represent about 40% of the whole benefits that have been delivered to society. Some of them are more difficult to quantify, like, we haven't perhaps lost as many days off work because of improved health, perhaps less policing costs because of reduced crime, because of improvements in security. All these things are more difficult to quantify, but they nonetheless will be savings. But perhaps quite impressive for social landlords too is the impact Decent Homes has helped to have in terms of the energy performance of the stock. You can see obviously the SAT rating, which has always been higher in the social sector compared to the private sector anyway. Huge inroads there, important reduction in CO2 emissions, and perhaps very good news for your tenants. We believe the average fuel costs have reduced by over around about £100 a dwelling, which is, a really good news story for your tenants, we think. At that point, I'll hand over to Ian, although unlike Colin, I will get my plug in to say that copies of the research, if you are interested, are available at BRE reception or can be found on BRE online. Make a nice sort of present maybe to your tenant boards or your director, extolling the benefits of all the hard work. Thank you.
Right, thank you very much for that, Helen. Right, but at the BRE, we've made it in the main local authorities in the recent past, a health impact assessment service. And as we've now got this new methodology, this new research undertaken on decent homes, it's something that we're now able to offer to registered providers, where we're able to actually look at the benefits on health and the potential savings to both the NHS and wider society from those housing improvements that perhaps have already been carried out, or perhaps look at those, so looking at a retrospective health impact assessment, but also look at the properties perhaps which remain non-decent, which we call a prospective health impact assessment. So what we wanted to do was certainly take advantage of all that work that has been carried out in that publication and put it together and offer it as a service to yourselves, particularly because local authorities have found it so useful over the last few years. If you've already carried out the improvements to your housing stock, so they're all meeting the Decent Homes standard, we're able to offer a retrospective impact assessment. This may be of benefit to you, and certainly welcome your feedback and any comments on this service, because as we just described, it is brand new, so we're yet to actually pilot it with a landlord. But it may be that you want to identify and celebrate what you've already done. So all that inconvenience and problems that have occurred over the last 10 years in improving the housing stock, you may wish to celebrate an actual outcome of that. It may be that you wish to demonstrate the impact to tenants and thank them for cooperating as well with those the inconvenience and with those contractors who perhaps weren't always keeping their time commitments and things. It's also useful to demonstrate commitment to tenant health and well-being and the contribution to tackling health inequalities. And perhaps it's also useful if you're interested in making health and well-being a corporate objective. I know that some registered providers have signed up to this well-being, the 5 ways to well-being model. And it's a way to demonstrate to tenants that, look, we firmly believe in your health and well-being. We've made the properties safe. They're now decent. They're not contributing to your health. Therefore, perhaps it's about time you looked at other things that could improve your health and well-being. It can also be used as evidence to maintain those and keep those homes decent, because that's going to require ongoing investment, and also to promote your housing offer. There's a lot of talk about the housing offer to health, particularly by the CIH, and I've tried to summarise in this slide really what that's about. Fortunately, there's a real acceptance now of the association between housing and health. And if you look at these various different indicators, you can start teasing out elements that are quite relevant to the housing world. So, for example, here I've got in this colourful table a number of the public health outcomes. So, for example, pupil absenteeism, that could be linked to cold, damp homes, perhaps where children are more likely to be ill. It could be, for example, falls and injuries in over 65s if there are lots of falls hazards in those homes. So there's clear relationships between those health outcomes and the condition of properties. So that's if we're looking back at the properties that we've already made decent. If you're some of the housing associations or own some of the stock, the 20% stock, which still doesn't meet the Decent Home standard, then what we're able to do is a prospective health impact assessment to estimate the cost to ill health of housing in its current condition, and what the difference would be if it was improved and made decent. So this just goes to show that there are still 760,000 dwellings not meeting the Decent Home standard, with the biggest proportions found in the local authority stock. So again, why might it be useful? It's very useful for engaging with health services, for example, the clinical commissioning groups, the health and wellbeing boards, because you're able to demonstrate, look, these properties in their current condition are causing the X number of injuries and illnesses requiring medical attention a year. Why not help us fund some improvements? So it's useful for putting together funding applications, and perhaps also adding value as well, or looking at contributory funding with those different organisations. So you can build an offer to meet the health priorities and trying to assist those services meeting their own targets, and demonstrate the value and cost benefits of investing in housing. It could also be used for engaging with tenants and encouraging cooperation with tenants, perhaps to allow access to contractors. And also, once you've carried out housing improvements, it can often ignite wider benefits. I remember speaking to someone up in Glasgow who was saying that the tenants that he was looking after, lots of smoking, a lot of people drinking too much. And he said, well, if you go to the home, it's all damp and dark and cold, and they've got very little sort of self-respect. Yet when we improved their homes, they felt much more proud about it. They were more happy to allow other visitors and guests into the home, and they felt a greater sense of worth. So it was at that point that they were more likely to take up reducing smoking and alcohol consumption, that sort of thing. And it can also help to prioritise works as well. If you can't afford to do all improvements, then perhaps you can prioritise those that have the greatest impact. So as I say, we haven't yet done this for a landlord, but I've got a couple of examples from local authority reports that we have done. So Helen's already mentioned about the 29 different hazards that are considered under the HHSRS system, which I've tried to clump in the left column there. Also listed there the main health conditions associated with each one. And I think what's most important here is the estimated number of instances requiring in medical attention. I'm a bit concerned about moving away from this microphone because it can't even be recorded. But if you see this column here, this is the housing stock in its current condition. It's quite a large local authority. What we're saying is that for the hazard of excess gold, there are 47 instances requiring medical attention each year for the hazard of excess gold within that private sector housing stock, like 700 for the down and low sector. If we were to improve all those properties up to average or make them decent, then statistically there's still going to be a risk. You can never eliminate this to health and well-being. We can certainly reduce it, and this would be the contribution that housing would make to health and well-being across the stock if it was improved. So the next slide helps to sort of summarise that. So for this large local authority in the northeast, we said that if you were to improve all private sector housing, remove category 1 hazards, you could potentially reduce hospital admissions or medical interventions by almost 2,300 per year. Yes, that's going to cost a lot of money, but that's potentially what you could do. We can also provide various charts and diagrams to demonstrate the cost to the NHS. So we've looked at the health implications of substandard housing. This is the financial cost to wider society from tenants being exposed to hazardous housing in that particular area. So for example, just for the hazard of falls on level surfaces, that's costing wider society almost £2 million per year. So again, it's trying to produce compelling reason why to invest in housing. We can demonstrate it in a bar chart form as well, so that listing the different hazards across the bottom and the potential savings to society. This shows private stock, owner-occupied, private rented, and we can also identify the properties that are in the most deprived areas of that, well, of the country as well, which you can't quite make out on there, but if we were to zoom in, you could. Clearly, we'd be replacing that with the social landlord. We can also provide payback examples. So here's an example of quite a steep staircase that doesn't have a balustrade. The cost to remedy this hazard would be in the region of £314. Because it's particularly high risk, there's a very high likelihood of someone suffering ill health as a consequence of the condition of that staircase. It would statistically save the NHS £146 per year. So the payback period is just over 2 years. So which is particularly perhaps useful if you're looking at a prospective health impact assessment. You can start looking at what's worth spending money on. This just goes again to show the effects of £50,000 annual expenditure and the savings from tackling stair hazards. So if we were to spend £50,000 per year, accumulates, this is the saving. As you can see, when we get to sort of year 5, the difference is quite marked. Because what we're saying is that the improvements you make in year 1, they're still going to be there in year 2, year 3, year 4, and year 5, and so we can actually project it over a 10-year period. We can also produce various maps, GIS maps. This was one we did for Barnsley, showing the cost to society from health hazards in the home. So it normally follows a trend of where the more populous areas are. But again, it's quite useful if you've got conversations with the health colleagues to say, look, this part of the area is costing you guys the most, and perhaps this is where we need to intervene and improve housing conditions first. This is what we charge at the moment. As I say, this is a brand new service, so we're sort of aiming again for when we've worked out the amount of time it would take us and the costs. We're aiming for a cost of about £10,000, but obviously it depends on what the client would like, if they wanted to consider certain things. I mean, for example, we can start looking at incidents of COPD or I've got myself now, COPD, respiratory problems, chronic obstructive pulmonary diseases, because some local authorities have asked us to map that over instances of excess cold, so obviously that takes a bit longer, and it also depends on the type of data that you hold and how we're able to convert that into a format that allows us to model those health benefits. I think that was all the time that we had. So, yeah, certainly invite some questions.